Hello friends, I am Dr. Rajiv Kovil and welcome to the 20th edition of Diabetes News Nucleus. Diabetes News Nucleus is an endeavor which is supported by Mankind Pharma and presented to you by Metabolic Health Digest. And what is our mission of Diabetes News Nucleus? The mission of Diabetes News Nucleus is to get you the best in the metabolic space so that it can enrich your practice. It can also give you some kind of strategies which we can help our patient community. So let's look at the headlines for this particular month. The American Diabetes Association Scientific Congress just concluded at New Orleans last month. One very interesting study which came out of it was called as the RECOLAR study. I'll tell you what RECOLAR was all about. RECOLAR was a very small group of patients, just around 24 patients. But what they looked at is 4 groups. One was on an ARB, one was on an empagliflozin, one was on a combination of an ARB plus empagliflozin, and fourth was placebo. So basically we have now come to a conclusion that ACE, ARBs and SGLT2s are going to be the standard of care for patients with diabetes to prevent and treat chronic kidney disease. And here what did we see? 4 groups of patients, and the eGFR reduction with empagliflozin was very minimal. When we look at losartan caused a little bit reduction in eGFR. But when we combine these two drugs, the efferent vasodilation that it causes, it will help the hyperfiltration, which is the first phase of chronic kidney disease. And probably we need long-term kind of data to actually suggest that this combination of an ACE or ARB plus an SGLT2 inhibitor can prevent really hard endpoints in terms of chronic kidney disease. But here you have a hypothesis setting, small paper, small publication presented at the ADA that the combination of these two would enhance the efferent vasodilation, and that would help in reducing the hyperfiltration, which is the first phase of chronic kidney disease. Another very important study which was presented at the American Diabetes Association meeting this time was by Ilyas Penakis, who is from Maryland. And it has always been a speculation that whether we can use continuous glucose monitoring in inpatient setting. And there was a paper which came around 2 years back that probably streaming blood glucose level is also the 4th or the 5th vital sign. Similarly, this paper looked at 2 cohorts of patients, 180 patients on each side, and one was traditionally managed in the hospital with finger prick monitoring. The other one was put on a Dexcom G6, and there was a continuous glucose monitoring which was happening. And we looked at that whether our management would change. What was important is that patients who were on a continuous glucose monitoring system, we realized that as soon as they developed a hypoglycemia, the chances of a recurrent hypoglycemia, that's a blood sugar below 70, was reduced by almost 47%. And if you look at the critical threshold of 54, that was reduced by almost 70% as compared to the traditional finger prick. These were non-critically ill patients, inpatients. So if we extrapolate that to a clinical strategy, what it means that you don't have to put everybody on a continuous glucose monitoring, a diabetic who gets into hospital. But once a diabetic is there in hospital and develops a hypoglycemia in hospital or inpatient hypoglycemia, then it's time that we kind of sense him. And we sense him with a real-time glucose, and the chances of him going into hypoglycemia recurrent or a repeated or a next hypoglycemia is 47% lower when we look at a threshold of 70 and 70% lower when we look at a threshold of 54. So we all know that obesity today is a huge public health problem and a huge public health concern. And a lot of abnormalities, metabolic abnormalities in people with obesity drives cardiovascular disease. Today we know that 3% to 5% drop in weight can actually have a huge positive impact on cardiovascular health. And this has been an aim that there has been a debate around the globe whether we should also incorporate weight loss as a primary aim for people with diabetes. Recently there was a debate at the ADA also that whether HbA1c of 7% is better, or we should also look at 5 to 10% weight loss in our people with diabetes. This important paper which got published at the obesity, in the journal Obesity, looked at a very automated online weight loss management. And why it is important is that it's a very low cost resource. In a low cost resource setting, you can actually implement something like this. It didn't involve any extra in-person counseling or anything like that. It looked at 12 online sessions. Patients were sent a QR code to kind of register themselves, and we had almost 56% women and 44% men. We had around 464 participants, 12 weeks online training, and the average weight loss was 5.1%. And we know that 5% weight loss is mind-boggling. You know, an online approach and you can have a 5% weight loss. Till date, most of these approaches have given only a 2.5% weight loss. What was further achievable? What was this weight loss all about? One, you have to just log your weight. Two, you have to talk about your physical activity. Three, you have to talk about your energy intake. There are 12 online sessions. Importantly, people who attended the online sessions, all of them had almost an 8% weight loss. People who logged in their weight had a 7% weight loss. So just by introspecting on what you're eating, along with nudging from an online program, you can have significant successful weight loss management. And why notably it's important that you can put it on it's a scalable approach. You know, an online 12-week course is a scalable approach in a primary care setting. You can scale it to a much wider audience, and probably we can have a lot of emergent risk reduction in this public health problem, which is obesity. Another very interesting study which got presented at this year's American Diabetes Association Congress was the Retune study. So again from Dr. Roy Taylor, who did the direct study, and these were patients with type 2 diabetes who were of normal BMI. Now the direct was on patients who were overweight and obese, and we saw that whether we could cause a remission in them by causing weight loss and a hypocaloric diet. These were patients with a BMI of 24.8, and they were not overweight, they were not obese, but they were people with diabetes. And they were they underwent first 3 cycles of weight loss program where they lost around 5% weight. Following which they were put on 2 cycles of an 800 caloric diet for 2 weeks. And what we showed is that there was a good 10% weight loss. Apart from that, there was a 70% remission in diabetes to an HbA1c less than 6.5. An interesting finding again, that we all know that there is ectopic deposition of fat in the body. That seems to be the trigger point for developing diabetes. And what we saw was this in Retune study, that this ectopic deposition of fat, whether it was in the liver, whether it was in the pancreas, whether it was other ectopic tissues, was much reduced. The triglyceride levels went down, the fasting plasma insulin levels went down, thus setting a hypothesis that weight loss, even in people who are not overweight, can cause remission in diabetes. So this is a very significant finding from a strategy perspective, because earlier we thought only overweight people with type 2 diabetes can have a remission if they lost weight. Now we know that normal weight people can also have a remission if they lost weight. So these were very important findings for this month, and we will again come back to you with headlines for next month. But for this month we have a fantastic session on a burning problem. And why I'm calling it a burning problem? Because majority of our patients come to us with burning sensation of the feet. And diabetic foot is a huge, enormous public health problem, and majority of non-traumatic amputations across the globe is related to diabetic foot. Worse is the prognosis following diabetic foot. We all know that almost 50% recurrence occurs in the next 3 to 4 years. Out of the 50% recurrence, at least 50% of them undergo amputation. And following an amputation, the prognosis is very poor, and the 5-year survival rate is sometimes worse than majority of the cancers in the body. So that kind of importance to a problem like diabetic foot is not given. And the whole idea is to make sure that we have an expert in diabetic foot who can help you with certain guidelines which can actually help you in a clinical strategy in practice as such. So today to speak about diabetic foot, its prevalence, how to actually manage them, how to prevent them, how to diagnose them, we have one very big expert, one of the top endocrinologists of the country, and I'm going to introduce you to Dr. Manoj Chadha, who is the consultant endocrinologist at the Hinduja Hospital, Mahi, Mumbai. Welcome, sir. Thank you so much. Come, sir, come. Hello friends, I'm Dr. Rajiv Kovil here. Today we're going to discuss a very important aspect of diabetes and its complications, which is about diabetic foot. Foot by itself is a mechanical marvel. We have a lot of ligaments, tissues, bones, muscles involved. And if you all are not aware, a person in his lifetime walks close to 80,000 to 1,00,000 kilometers in his lifetime. So foot is put under a lot of pressure, and diabetic foot is very common a complication in people with diabetes, majority being type 2 diabetes. And today, to discuss this huge health problem, we have one of the most consultant endocrinologists of the country, a very well-known man across India, one of the senior most in Mumbai itself, Dr. Manoj Chadha sir. So Manoj Chadha sir is the consultant endocrinologist at Hinduja Hospital. We are just below Hinduja Hospital. He has his own center called Hope and Care Clinic at New Bombay, which is probably around 15 kilometers from here. And today we are going to discuss from him, and we're going to get some insights about diabetic foot infection and how we can prevent this. Thank you, sir. Thank you so much for coming to this show. So the first question, sir, is that why is there only diabetic foot and not diabetic hand? Is there any reason for this?
Okay, Rajiv, thanks for having me on the show. And it's a very important question. Why so much stress on foot management, foot care? Yeah, you're right. No one talks of hand care. Everyone takes care of their face without any comments.
Absolutely.
So, as you mentioned in the beginning, foot is a marvelous structure. 26 bones, 33 joints, 100 ligaments, tendons. So, it's wonderful. And you rightly said, it takes so much pressure. So, what happens is, in a diabetic patient, over the years, they develop neuropathy, they develop a vasculopathy. You know very well that diabetes is a vascular disease. In addition, if there are small injuries which normal person would feel or see, so because of their diminished vision, they miss that out. Diabetics, we know, are prone to infections, so a small thing can flare up. Poor nutrition, nephropathy, hypoalbuminemia, these can all contribute to a foot problem. Probably the hand is not as important. It is equally important because there are certain problems related to the diabetic hand also. But because of the length of the leg, the length of the nerves, and the fact that we are the first animals who are on 2 feet.
Oh,
Up
yes.
till now we were
yes.
all on 4.
Oh, yeah.
So that is an additional reason
pressure on
the feet. So we really have to take care of our feet. As a matter of fact, when I talk to my patients, I tell them, we know about so many complications in diabetes, but probably one which is nearly preventable is foot problems.
Foot problems.
And that's, I think,
but the magnitude of the problem is really big, isn't it?
It is.
You know, at a tertiary care center like Hinduja, I'm sure you must be seeing a daily flow of people with diabetic foot infection.
As a matter of fact, you know, diabetologists either have acute emergencies, the hyperglycemia or the hypoglycemia, or foot problems. I mean, really we don't need to admit our patients otherwise.
I agree.
And one of the things that I want to say right in the beginning, when we're talking in terms of numbers, they're huge. 30 to 40% of our patients would have some minor or major involvement. 1 to 2% may end up with amputations. And that is a huge number for any practice. Right at the beginning, that foot problems are inherent in diabetes. But smoking, which is, I think, again a big problem, the two together, 1 plus 1 leads to 11. I mean, I'm so particular about smoking and tobacco. I tell my patients.
Tobacco in any form, cessation of tobacco in any form.
Is very, very important. If you were to go into our hospital or any surgical ward, and you see a non-traumatic amputation, no accident, medical problems leading to an amputation, 99% you have diabetes and or smoking.
I agree.
That's how serious the problem is, and we really need to.
So, sir actually hit upon a very important problem, which is amputations. Almost 75% of non-traumatic amputations world over is related to diabetes. So amputation leads to a lot of problems. Disability, quality of life, and we also know the survival following an amputation is poor. Recurrence of diabetic foot is also very high. So tell me, sir, what are the types of diabetic foot infections?
Okay, good. So we discussed why a diabetic patient is prone to get foot problems. So traditionally, there are 3 types of diabetic feet we are talking about. The commonest probably is the neuropathic foot, because of neuropathy. Traditionally, problems start at the sole of the feet. They get callus, which is generally ignored. Someone looks at removing the corns, not to be done at a personal level. You should go to a doctor. The callus, if not taken care of, can progress to an ulcer. So typically neuropathic ulcers are on the sole of the feet and at the head of the metatarsals, the first, the third and
first
the fifth.
metatarsals, yes.
Yeah. So that's the neuropathic foot. Sensations are lost. Patients don't feel the pain and they just continue their life with it. The neuroischemic foot, again, we understood the vascular supply is reduced. These ulcers tend to occur on the medial or the lateral margin of the foot. So that helps you to diagnose, and obviously your treatment approach would be different. And very rare is a ischemic foot. In diabetes, pure ischemic foot is rare.
So what is common? Is it a neuroischemic foot or a neuropathic foot? Which is commoner?
Probably nearly 50-50 or 60-40. You have to keep both the things in mind, because when you talk of microvascular complications, it's not that one starts and the other is waiting to start.
It's always together.
So, the eye changes, the kidney changes, the vascular.
They all hunt together.
They would practically be about the same time. So that has to be kept in mind. Probably what we need to start looking at, if we are not already doing it, is our age-old tradition of touching the feet. It's a good habit.
It's a good habit. Yeah. So once you start examination with the feet, you feel?
Yeah, so traditionally we are taught of pulse and then look at the eyes. But don't forget to look at the feet.
So from the diabetes perspective, the metabolic physician should start from the feet.
Yeah.
So how do we evaluate the?
Yeah. So once you just touch the foot, you come to know, is it cold?
First, remove the socks. Yeah. Majority of the time, that's the number one. Remove the footwear and socks and come onto the table.
Come on the table. Yeah. So that's important. Touch the feet. Is it warm or is it feeling cold? That gives you an idea. And obviously, you look around. Are there any deformities, any ulcers, callus, things like that? You get an idea immediately. Feel the peripheral pulses. So that gives you an idea. Although it's not foolproof, but it still gives you an idea that things are reasonably good. We have 2 or 3 very simple tools that anyone can do it in their clinic. One is the monofilament test. I hope everyone is sort of aware of it, or we can always show it to them later on. It gives you an idea about these sensations. A simple 128 Hertz tuning fork. It gives you an idea of vibration sense. Temperature can be done if it's available, but otherwise just the touch, the vibration sense. If you have a biothesiometer, wonderful. It's not a big deal today. I think any clinic can afford to have a biothesiometer. So an annual 5-7 minute check, and every time a 10-second touch is good enough.
Is good enough. So just a monofilament, a tuning fork, and just palpation of pulse
gives you an idea. And one thing which I think we need to put in a little effort is to do an ankle brachial index. Blood pressure in the upper limb, blood pressure around the ankle, anything between 0.9 to 1.3 index is taken as normal. Lower obviously tells you that the blood flow is diminished, but even the higher value tells you that there's something wrong with the vessels.
There could be vascular calcification.
There is vascular calcification, and that should not be missed out. Just because it is 1.5 doesn't make you feel that the blood supply is really
better,
good.
you mean?
No, that's important.
And sir, if we get this, if a primary care level you find there is some problem, now how do we address this problem? Is there a prevention in terms of, see, we have to prevent in India, you know, there's no, it's cheaper than cure, is better than cure. How do we prevent and how do we counsel these patients? Because generally telling foot care guidelines to everyone doesn't help. If we kind of focus it on a group which has a problem, it helps.
Yeah, so that's why this initial assessment will tell you that, no, this guy is good, because we know if the monofilament is felt, 90% this guy is not going to have problems. Whereas if he is insensate and the monofilament,
the loss of protective sensation, the LOPS,
20 to 30% that in the next 1 or 2 years he is going to get
develop something.
Yeah, so prevention is much better than treatment. What we need to start talking about is the footwear to begin with. We have this tradition of barefoot walking. We go out barefoot. We at home we are barefoot. We go to religious places, we go barefoot. I think that is something which does not go well with diabetics. I'm not getting into social and religious things, but as a diabetic I tell them, please don't go barefoot. The other thing which is traditional in our homes is that Hawaii chappal. That should be discarded. We should either use a slip-on shoe, a canvas shoe, or if people are not comfortable with a shoe, then a sandal
with a backstrap.
You know, the floater and things like that. Anything which is comfortable, which covers the feet, fits well, is very important. Yeah? So one of the things when you're talking in terms of foot care is, what do you do when you buy a new shoe? Breaking in a shoe. Where the shoe,
usually people buy a new shoe when they have some activity to do. You know, they are going on a trek, going on a picnic, going on a vacation, and they start wearing it, you know.
Yeah, so that's not a good idea.
That's not a good idea.
Yes. You need to get used to the shoe. The foot has to get used to the shoe. So it's a good idea to wear the shoe for a short while. Like we say, okay, from home to work. At work you have a regular pair of shoes, and then when you're coming back, so you start with say 20-30 minutes or 60 minutes at a time. Break in, get used to it, and then hopefully you'll be very comfortable with that shoe. So I think footwear is very important. Self-inspection. I mean, today we have very simple ways. I mean, people have difficulty in lifting up their feet. My grandson can do that. he does that regularly. But for most of us, it's very difficult to look below. So if you have a little viewing glass, it's a good habit. It pays dividends in the long run. At the earliest sign of discoloration, some callus formation, you should talk to your doctor. And the physician should also take it seriously, not that this is nothing, leave it alone, we'll see later on. If you catch it early, it's good for you. And you said in the beginning, smoking tobacco is absolutely a no. I tell my patient it's not negotiable.
Absolutely.
You know, other things we could sit and bargain over it, but smoking is not it.
A lot of time our patients become surgeons. They want to remove their callus, corn. They don't know how to cut nails. So in any, you know, we all know that on the corn cap it's written not to be used, but we see a lot of people using it, getting an infected corn and coming. So what's the advice for all these homegrown surgeons, as we can call it?
The simple answer is, please don't do self-treatment. Corn caps are not to be used because not only do they work on the corn, but they work on the surrounding normal skin, cause corrosion, erosion, and actually can lead to a bigger problem. So please don't use corns. Let the doctor, and I think most doctors can learn how to do it.
Exactly.
At this stage, probably we should thank Dr. Arun Bal, because he has taught us most, I think, of the doctors in the country. If they talk about foot care, it's thanks to Dr. Arun Bal.
True.
And he has given us enough courage to do it ourselves. I don't do it, but if someone is interested, it's easy to learn.
Absolutely. And nails, cutting of nails.
Very, very important. See, when we are talking of our fingers, we want the nails not to be visible, not overgrown, so we cut it very close. But when it's toenails, 2 to 3 millimeters beyond the skin is what we would recommend. And especially with the big toe, this issue about ingrowing toenails.
Sometimes there's a lot of fungus growing also, sir. You tell them to file only rather than cut. Is there something like that?
So that's again, now that is a branch which by itself is also developing. So the nail care, the paring of the nail, the filing of the nail, these can be done either with self or with someone at home and taking care of it. So while we are at the fungus point, looking in between the web spaces. Because
interdigital macerations, yes.
Not getting good aeration can lead to fungal growth in diabetic patients. So that should be also caught at the earliest possible.
And a lot of people have these crowded toes, hammer toes, claw toes, and some of they don't actually appreciate that there is a problem, and there we have to tell them to kind of clean in between.
When we were talking of the neuropathic foot, we discussed about the callus, corns, ulcers, but deformities is an important part. And what you very rightly said, the hammer toes or the crowding, the hallux valgus, these are warnings. If we correct our footwear, we get someone to make a good pair of shoes for them. Doesn't matter if they're expensive, because you can't put a price on your feet.
Absolutely.
So to have your intact feet is just worth anything. So a good pair of comfortable shoes could help correct these deformities. Our knowledge of these problems has increased so much that proper insoles, the spacing of the foot, these things can help reverse to some extent. Otherwise, our ortho colleagues are there. They can help us with surgical correction, because again, repeating, an ounce of prevention is better than a pound of cure.
A lot of time people get this infection because they go in for pedicure, and those saloon guys put these things and try to, and then you have the next day coming with an ingrown abscess or a toenail abscess. So these are the lack of education about it.
Yeah, I think so. The level of hygiene, if you have to go to someone to doing a pedicure, you need to be sure where you are going. And you're right, if there is an earliest sign of infection, please treat it aggressively.
Please treat it aggressively.
That's important.
So we've covered almost everything, sir. Any overview of management principles would you have? So it's a huge subject in itself. Diabetic
foot. For those who are really interested, there are two classifications of foot injuries and foot deformities which everyone should be aware of, at least in the name. And the classification, it's very simple. It grades from 0 to 6. So you can understand 0 is just be careful, and 6 is you need to take immediate action. So depending upon whether it's just a callus formation, whether it's going superficial ulcer, going to the muscle, going to the bone, so you have the grading. And similarly, in addition, whether there is infection or there is just inflammation, ischemia. So Texas classification takes all this into consideration, and obviously you have a prognosticating factor in that. Any situation which you feel needs an intervention with a surgeon, please have a surgeon on board. There's nothing wrong in calling in a surgeon. An abscess has to be drained, and remember, what you see at the top may not be the whole retreat, because the problem may not be skin deep but bone deep also. So you have to go for aggressive surgical management, wound debridement when necessary, proper antibiotics. These patients may need parenteral antibiotics for a few weeks. If it's just a superficial infection, oral antibiotics may do. A good idea is to get a culture, identify the organism. I know most of them are staph or strepto, but you may have a pseudomonas infection or something.
Or a mixed infection also.
So then anaerobes also.
Anaerobes.
So proper antibiotics for proper duration is very much necessary. And the other thing that we need to keep in mind when we are talking of surgical intervention and correction and antibiotics is offloading.
Oh, absolutely.
The patient,
which is never understood.
Yes.
You remove the callus and patient is walking from next day on.
I remember a very senior executive in my early part of my career, tobacco chewer, poorly controlled diabetes. He went for a conference. Sunday morning, they went for a dip. He came out of the pool, walked barefoot, went to his room. Next day morning when he got up, his whole foot, both feet were blistered. We had to obviously put him in the hospital, and he was a senior executive with UTI, I don't mind telling that. And I had to tell him, sir, let me assure you, UTI will continue to work if you are in the hospital for a few weeks. We had to hold him back. Until date, I use the progression of his foot as photographs while taking a lecture.
Okay.
So because healing is good when you've taken good care, but after that scarring, the deformity that remains. So that is another science by itself. So we know that a diabetic foot is vulnerable for more injuries, infection, deformities, but a deformed foot is prone to
more
further. So you mentioned
as the reinfection comes almost 50%.
That's why it's very important that we take care at the beginning. We talked about prevention, and if there is a problem, we manage it aggressively, and then rehabilitation. So that's again where we go to good footwear. Avoid tight shoes. Again, canvas shoes are a better option, but then if you have to go for a formal meeting, that's for a short period. One of the things that Dr. Arun Bal used to teach us is, if it does come to amputation, then the minimum that you need so that the healing is good, so that's decided by the vascular flow, etc., etc. Because trying to save the foot reduces the pressure on the heart. We talked about morbidity and mortality of foot care. So that's what is important. So having a deformed foot with good footwear is better than having the best prosthesis with an amputation, whether it is above knee or below knee. So we have to try and
prevent amputation. So sir, before we close, what are the basic investigations that you would ask for when a patient comes to you with diabetic foot infections?
So if you look at the foot part which we discussed, if you just put it all in order, you need a monofilament, the tuning fork 128 Hertz, a biothiometer if it's done, an ankle brachial index. If you have a fancy center, then the transcutaneous oxygen measurement. Otherwise we can do without it.
Okay.
You need to have a proper eye checkup, a urinary albumin creatinine ratio, the basic biochemistry, and obviously an HbA1c to tell him where he stands and where he needs to go. If there is a need for intervention, probably then vascular imaging, whether you're talking in terms of a Doppler study, and if there is a plasty that is going to be done, then you need an angiography before that. So it's all the first part has to be done, but the rest that follows is dependent
on what it is. So basically an X-ray to start off, followed by imaging modalities. Sometimes you may require an MRI to look at an abscess and all those things.
We have got fancy nuclear imaging also.
Nuclear imaging also.
Then we're dealing with infection.
Osteomyelitis and stuff like that. Yes,
absolutely.
So any closing statement from you about diabetic foot infection, and what we can do as a doctor community, and what the patient at large can do, because foot is neglected.
So I have a very simple message to give, that with all the complications that we keep talking about in diabetes, probably foot complications are the most preventable, and if you catch them, they are manageable and you can stop their progression. Keep your feet healthy, you'll keep moving, because it's a very sad state to see people with amputation or homebound because they have had this issue. And I guess we keep you healthy. You can keep your weight under control, you can move around, your social status, your occupation, everything is dependent
upon your mobility.
Yes, that's really important.
Absolutely. So you heard from the expert today that how diabetic foot is an enormous burden on every person living with diabetes. He spoke about smoking cessation, that is one of the most important messages that we need to give, that it can really help prevent diabetic foot infections. Diabetic foot infections can cause a lot of trauma because amputation is very high, and amputation, as I said earlier, is affects quality of life, is at very high risk for other complications and very, very poor quality of life. disability also. You live a life of a handicapped person. So that becomes a huge mental, social risk and the burden that the person with diabetes carries. So in a nutshell, we covered the whole diabetic foot, right from prevalence, what are the complications, how in clinic, in a primary center, one can actually detect diabetic foot infection, give them preventive guidelines, because a final mission for this kind of a talk is to make sure that we are able to identify the foot at risk. That's very important, because we have a huge 70 million people with diabetes, which again means 140 million feet, you know. So we have to identify the foot at risk, we have to give them focused foot care guidelines, we have to prevent diabetic foot infections. If we get a diabetic foot infection, early prompt diagnosis and aggressive treatment, and we have to prevent amputation at any cost. So thank you all for a patient hearing. We had one of the best endocrinologists in the country with us today, and we will again meet next month with another top KOL from anywhere and in any other part of the country. Thank you all for a patient hearing. Thank you, sir. Thank you so much. Thank you very much. It was a wonderful session. Thank you so much.